Hey guys, I'm Dr. Roshan Nasimuddin. I'm a consultant pathologist and I'll be talking about fine needle aspiration cytology. Let's look into the name. Fine needle aspiration cytology. So it basically means we use a fine needle to aspirate cells from a patient's body and examine it under a microscope to come at a diagnosis. So basically it is for swellings. So if a patient has a swelling somewhere and the swelling can be noticed by the patient himself or herself looking at the mirror, or it can be found by a relative or a friend or even doctor who is when the patient comes for some other complaints and doctor incidentally detects a swelling, either it may be thyroid or a lymph node. So any swelling that is detected by the patient, by friends, family, or even incidentally by a doctor, that has to be examined, because any swelling is potentially dangerous. Because swelling is the danger with the swelling is we have to know if it is cancerous. So we have to rule out the possibility of cancer. So any swelling a person has, it has to be examined, and there are many methods to examine the swelling, and the simplest, easiest and cheapest one is fine needle aspiration cytology. Other techniques are, we can take a biopsy, we can take a true cut biopsy, we can take a wedge biopsy, or we can excise the whole lesion depending on the size, the location, etc. There will be the difficulty of the surgery may increase or decrease. But fine needle aspiration cytology is very simple. It is a very kind of an office procedure. It takes less than 5 minutes. The patient won't have any long-term or even short-term complications, very small complications, if any, about which we'll be discussing shortly. So the patient can come to the procedure room and have it done and gone back within 5 minutes. So basically, why do we do this procedure? A patient has a swelling, and as I already told, we have to rule out if that swelling is carcinogenic, it's cancerous. So it's not just cancer, it can be due to tuberculosis, or it can be due to infectious conditions, it can be an abscess. So such many variety of conditions would be there, but our primary concern would be cancer. So that is why we do it, and the patient can come for the procedure, and we don't even require any kind of anesthetic. But for children, we may use topical anesthetic, because to avoid that fear, apprehension, and a little bit of pain. But even though we use the topical anesthetic, a little bit of pain would be there. And as for adults, the pain that we will be having is that of a pinprick, because it's basically a pinprick. We'll be using the needle to prick the site, so patient will have that kind of a pain, nothing more. There is not a surgery, there is no incision, nothing, there is no suture. So patient doesn't have to come for a suture removal or nothing like that. No additional medications are also required, just the needle prick. But the patient has to have adequate food and water before coming, because some people can have or can lose consciousness because of maybe a vasovagal or something like that. So it's better that the patient comes after having food. We have observed many patients who do not take food and come in their empty stomach and can lose their consciousness. But that is very rare and it's avoidable also. So that is why we do it. We do it to detect whatever conditions we can find out. It means what the diagnosis of the patient is. Again, another thing that we have to say parallelly is, fine needle aspiration cytology is not a definitive diagnosis. We can usually get a diagnosis, but it is not a definitive diagnosis. Definitive diagnosis is a biopsy sample, where a chunk of tissue is taken from the lesion or swelling, and that is processed and examined as a block. But fine needle, we are only looking at a few cells, so it may not be complete, it may not give a complete picture. But the good thing is that it is less painful, very cheap, and very less time is required. There are virtually no complications. But again, I have to say this, it is not a definitive diagnosis. or it may not give a definitive diagnosis. Many times it will give, but many times we may not get a real diagnosis. And sometimes you may have seen in the report, it'll be told that kindly excise the lesion or take a biopsy to rule out a condition. So that is one small disadvantage, or rather a bigger disadvantage of this procedure, that it is not a complete, many times it is not definitive. Sometimes it is, but many times it may not be. So that and how we do it, we'll tell the patient to come to a room, means with a privacy, of course, and we'll come to the procedure. This is the two methods of doing it. Like, we can either use a syringe, or we don't really need to use a syringe. So people can, or doctors will use either of these techniques. So here, the first one, we can use a syringe. And if you see, this patient has a swelling here, and a needle is there, and this needle is attached to a syringe. So this is the first method many doctors will do, and this is an accepted procedure. Both are accepted procedures. And this needle is inserted into the swelling, and this needle, the syringe, will be used to aspirate contents from the swelling, and this aspirated contents will be spread onto a glass slide, and this will be smeared on the glass slide, and that will be stained and examined. So we'll be aspirating with a syringe. So this is one technique. The other technique is, we can just use this needle without aspirating. We'll just put this needle into the lesion. We'll move in various directions. Once the needle is within the lesion, we'll move it in various directions, up and down motion, and that is enough, because the needle has a very small diameter, and that means there will be a capillary force, and that capillary force will it by itself force cells into the needle, into the core of the needle, and it can a syringe can be used to push down the material inside the needle, the lumen of the needle, into a glass slide, and the rest is same for both. So we can do either of these procedures. It depends on the wish and ease of doing for the person who is doing the one who is doing the procedure. So both are acceptable methods. So this, we can see that first we'll put the patient into whichever position he or she is comfortable in. It can be lying down position or sitting, depending on the site. Ideally it is a lying down, because if a patient goes into shock, or not shock, loses consciousness, or vasovagal attack comes, there is a chance that they may fall off. So it's better always to make the patient lie down. Anyway, once the patient is in position, we have to clean the site. We have to clean the site, and we have to disinfect the site. And after that, we'll take the needle. Here we can see that a syringe is attached. So this person might be doing the aspiration technique. Some people may attach a syringe and yet not do the aspiration technique, because as for me, I just attach the needle and I don't aspirate, but I attach the needle so that I can use it to maneuver within the lesion. So it will help to hold on, because if you just take the needle, it's little space to hold. So if you use a syringe, you can hold onto it, and we can maneuver the needle within the lesion. So it depends on the person. Anyway, we can see that after the site is cleaned, with 2 fingers, the swelling is held into position or immobilized. And once that swelling is immobilized, a needle can be inserted into the lesion, and an up and down motion can be done or aspirated, depending on the wish of the person. And once that is done, it is pushed down into a needle, into a slide. And we can see here something is marked here. That is a unique number for this patient, so that we don't misdiagnose, or we don't mix up the patients, basically. So we have to mark the slides before we put the specimen into it, or we push the aspirate into the slides. So every slide has to be marked, and this corresponding number has to be there for the patient somewhere else, where we can look back and see that this slide belongs to that particular patient. So no mix-ups should be done. We should be very careful with any mix-up, because the diagnosis will be interchanged. So that's a very dangerous thing, and that is something that we should always be careful about. So some problems that can arise. So these are the problems that might arise. So here, when we directly put into the center of the swelling, sometimes some swellings can have a necrotic center. This area might be necrotic. So the problem is we'll get only necrotic tissue. That is seen here. See, we'll get only necrotic tissue, or it may be empty space. Sometimes the whole lesion can go on to be cystic, and this may be an empty space. So if this is a necrotic space like this, or an empty space, so we'll take this A as the ideal one, and so C, let's see, this is a necrotic or an empty space. Here it is an empty space. We can also consider it as a necrotic. So if it is necrotic or if it is an empty space, we won't be getting diagnostic or viable cells. What we need is, we need viable cells, alive, or cells that were alive when we aspirated. So we may not be getting viable cells if we aspirate in an empty space, that is a lesion which has turned cystic, or if it is completely necrotic in the center. Because why does a swelling become necrotic in the center? Because that is where there will be least blood supply. Because this if suppose this is a cancer, it will be getting nutrition from the vessels here. So these areas will be getting vascular supply, that is nutrients from the vessels here, so they will be alive. So once the lesion becomes big, here the center part may not be getting nutrition, so that area will die off. Okay, and here we'll just consider the ideal. So correctly, if means the needle will be going into the center and we'll be getting a diagnosis here. But here we won't be getting, and here obviously we won't get, because the needle has completely gone away and just gone to the side of the swelling and missed the swelling completely. So here also we won't be getting a result. Here the problem is we will get a result, but suppose this is the cancerous or the area affected by tuberculosis or an infection. So we will not be getting the diagnosis that we want to get, because this may be a completely benign or less problematic area, and we'll be diagnosing only with this, but here we may completely miss. So that is one problem. And here this is a lesion that may be very much fibrotic, see, like bands of fibrosis. So when we have such a lesion, the problem is that due to the fibrosis, the cells may not come back into the needle. So if the cells won't come into the needle, we won't be able to aspirate, and if we are not able to aspirate, basically we won't be able to if we are not able to aspirate any cells into the needle, we won't be able to examine any under the microscope. So that is another problem that we might face. And so this, after we make a smear, what can we do? We can actually make a dry smear or a wet smear. Wet smear, that is when we directly put this slide into an alcohol fixative. So if we are not using an alcohol fixative and we are allowing the slide to dry, that is basically a dry slide, and that we can use Jeams, etc. For the other one, alcohol fix, we can use pap smear to stain. So by the way, what is staining? Staining is a procedure by which we stain the cells. That is, these cells that will be coming into these slides, they will be colorless. So we cannot examine these colorless cells under a microscope. So to examine these cells under the microscope, we have to see the cells. So to see the cells, we will give them some colors, and the way to give these colors is what we call as staining. So that we can use different techniques like Papin-Color staining method, or we can use Jeams, etc. So there are many methods to do staining. We can even use HND staining, even if it is cytology, though usually not done. So that is about basically about FNAC. Now, which are the things that we usually, which are the sites that usually comes for FNAC? Thyroid is the first thing. Among the most common of cases that comes, that is, someone notices that a person has an enlarged thyroid. So thyroid swelling, we can easily do this procedure. So the common conditions are thyroid swelling, then lymph node swelling in the areas that accessible easily, like axillary, cervical, that is the neck area, then inguinal or between the legs, that area, the groin area, That is the lymph node. Then the breast swellings. Breast swellings can be diagnosed with this procedure. Means basically everything can be diagnosed. I'm telling the common ones are thyroid, breast, lymph node, then salivary glands, then cystic lesions of the neck sometimes. So those are the main things usually that comes to us. That is all about FNAC, and thank you for listening. Thank you.